54, can you guys hear us?
Where's the mute button? It's the space bar.
I'll take that as a yes, you can hear us.
How are you?
Thumbs up, high, wave,
So
something.
great. So great.
Are you cut yet?
What's that?
Are you cut yet? No.
2 weeks.
2 weeks?
Yeah, 2 weeks.
Are you ready?
Was born.
Okay, Jello and chicken, that's it?
There's lunch, some veggies.
Oh, there's veggies, there you
Are
go.
you in competition?
Yeah. We'll do it by
When
the
is it?
show. October.
Can we get tickets?
I think it's on our first day then. But I'm coming in.
Can you not hear us?
Dude, I will take time off.
I'm coming in the second day.
Oh,
I
legit?
said like, hey, can you hear us, can you wave or anything? Nobody waved, so just making sure you.
Just someone illegally streaming.
Okay, we're gonna get started.
I come out 2 weeks.
Alright, thanks, bye.
Okay.
Okay. Do we need to wait for Jaloon or anything, or do you wanna get started?
I'm happy to get started.
Okay.
That's whatever you guys.
Alright,
works
feel
for you
free.
guys. Okay.
I'll let you do your own introduction since I don't know your background, other than what I could read right there,
That's
but.
pretty much what I was gonna say.
Alright, it's a pretty easy crowd, I promise, we'll take good care of you, alright?
Took them up there.
So,
Let's go.
my name's Bhavani Kura. I'm the stroke medical director at Davis Hospital and a neurosurgeon with the University of Kentucky. Just feel free to interrupt with questions, or if you want me to talk about something in more detail, I'm happy to. Okay, so about stroke. So a few facts about stroke. Almost 800,000 strokes occur in the U.S. each year. 5th leading cause of death, a leading cause of disability or morbidity. And about 1.9 million brain cells die on average for each minute that a large vessel stroke goes untreated. And I just want to clarify that that's not for every stroke. There are strokes that involve tiny vessels in the brain, but for a large vessel stroke, 1.9 million brain cells die each minute. The indirect and direct cost of stroke is more than $50 billion every year in the US, and that's actually a number from 5 years ago, so I'm sure it's higher now. And stroke, involves all ages, races and ethnicities and socioeconomic groups. So this shows the distribution of strokes based on age. And you can see they do more commonly occur in people in the elderly, but they do occur at any age. And this actually starts at these diagrams start at age 20, but actually even children can get strokes as well.
Why is it more common in women?
Lifespan? That's what I was just thinking. Is it because women tend to outlive men past
Like
75? Is that why there's a
more
greater
so-
distribution
more so
with females
with
greater
age.
after 75?
That may be. I'm not sure about the detail on that actually. I wonder if also they get diagnosed more frequently.
Probably because they actually listen to their bodies. Most of those men are like, power through, dude. You'll be okay. Your face is drooping, you'll be okay.
Get
off that wall. Yeah. Don't shake it off.
It is possible that minor strokes with minor symptoms might get diagnosed more frequently in women. Also, I'm actually not sure about the reason for that. I have to look into that. Whoops. Okay, so there are 3 stroke types. I'm using these 3 stroke types, but there are actually multiple ways that you can kind of differentiate strokes. But ischemic strokes, intracerebral hemorrhage, subarachnoid hemorrhage. So ischemic strokes are definitely the majority of strokes, where a clot occludes an artery in the brain. I'll start with ischemic strokes. A little bit more about ischemic strokes. Again, it's basically an artery in the brain that's blocked, blocking blood flow and oxygenation of an area of the brain. About 87% of strokes are ischemic, and then there are 2 types of ischemic strokes. So basically differentiated by where the blood clot is coming from. It can come from somewhere else in the body, such as from the heart, and that is an embolic stroke, or thrombosis, so the clot actually occurs in the artery in the brain, and that's where it stays. And then a stroke caused by a large vessel occlusion is a more severe type of ischemic stroke, and has some additional advanced care possibilities. Okay, so what is a large vessel occlusion? So, actually, I think there is I should point this way. So, a large vessel occlusion involves the the vessels of the brain that are delineated by the yellow rectangle, but the internal carotid artery, the middle cerebral artery, or the basilar artery. And they encompass 40 to 50% of all ischemic strokes. They have a higher mortality, more morbidity, and they don't respond well to IV thrombolytics such as TPA or TNK. So successful opening of the artery with a thrombectomy is associated with a better outcome though. So here's an example of a large vessel occlusion. This is the middle cerebral artery coming off. Basically you can see that the skull is in white as well as the blood vessels. This is a CTA. This is the internal carotid artery and then the middle cerebral artery coming off. But you can see some blood vessels here, some little white spots on this side that you don't see well on this side. So there is a cutoff of blood flow around here in the middle cerebral artery. So this is in the cath lab. So this is the initial contrast run. This is actually the anterior cerebral artery here, but this is where the middle cerebral branches should be coming off. But you don't see them over here on this side, but this is after thrombectomy where blood flow has been restored, and so now you see the branches of the middle cerebral artery. And then this is the blood clot that was retrieved. A kind of subset within ischemic stroke is a transient ischemic attack. So you can get similar symptoms to an ischemic stroke, but they're temporary. So they're caused by a blockage like an ischemic stroke, but you don't get the damage to the brain. The symptoms are temporary. They do still need to be evaluated quickly because a certain percentage of these patients do eventually have an ischemic stroke with permanent damage to the brain, and so we do want these patients to still get evaluated and worked up for the potential reasons for the TIA and whether they need like anticoagulant medications. You know, they won't receive TPA or TNK, but they might get started on some medication to help prevent a full ischemic stroke. So common stroke symptoms. So the ones on the left side are the ones that people most commonly hear about and see in strokes. So they're the hemispheric symptoms. So weakness on one side or numbness on one side, trouble with speech, maybe a gaze preference. The ones listed on the right side involve the posterior circulation of the brain, which supplies the brainstem. So this is the brainstem here, and then this is the cerebellum. This is a basically side view of the right half of the brain. So less commonly seen symptoms, also less commonly known symptoms. So nausea, vomiting, again, you can have some speech problems. Headache is more likely in posterior circulation symptoms. Abnormal eye movements or changes in vision. There are these crossed findings, which are pretty specific to the brainstem. A symptom on one side of the face and the opposite side of the body. So I'm going to talk a little bit more about these posterior circulation strokes because they are less well known and more easily missed.
Can I ask you a quick question about that?
Yeah.
And maybe you'll work it into this conversation. I once had a physician tell me that complete loss of consciousness is not typically or often associated with stroke, and that if they have a complete loss of consciousness, it's likely related to something else, not stroke. Is that an accurate statement?
Yeah, I would say that because you're not typically, I mean, the most common strokes are those hemispheric strokes,
Right.
so you get the things like weakness on one side, that kind of thing. And so they are not likely to have any sort of, loss of consciousness. Potentially with a brainstem stroke, you could, but even still, it's not common for, a brainstem stroke either.
Right.
Typically, they will present with other things.
Right.
So,
Thank you.
yeah, I would agree with that. So more about the posterior circulation stroke. So this is the posterior circulation of the brain, these blood vessels here. So this is basically showing the underside of the brain and the blood vessels. So this is the internal carotid artery and middle cerebral artery. So those supply, I think it's each internal carotid artery supplies about 40% of the blood supply to the brain. So that's 80% in total of the blood supply to the brain, and the other 20% is supplied by the posterior circulation. So these are the vertebral arteries. They come up the upper spinal cord, and then the basilar artery, and then posterior cerebral artery is coming off here. And they supply these areas of the brain. So this is the brainstem, the cerebellum. Again, this is a side view of half of the brain. This is the thalamus, this is the occipital lobe, basically back here. And then this area of the brain can be supplied either by anterior circulation or posterior circulation. It's more common to be anterior circulation, but I'm going to talk a little bit more again on posterior circulation strokes. So they are approximately 20 to 25% of strokes, which makes sense with what I was talking about as far as the posterior circulation supplying about 20% of the brain's blood supply. But they account for a higher percentage of unfavorable outcomes. They are more likely to be misdiagnosed or missed compared to anterior strokes. Which makes sense because the symptoms can be nonspecific and variable, especially compared to hemispheric strokes or anterior circulation strokes. And our stroke scales don't really adequately include signs and symptoms of posterior circulation strokes. And that's for both pre-hospital stroke scales, so the stroke scales that you use, as well as we use the NIH stroke. Once somebody's in the hospital, they get evaluated with a NIH stroke scale, and so even that doesn't adequately represent signs and symptoms of posterior circulation strokes. And then, onset to door to imaging, door to treatment times are higher for posterior circulation strokes. So a little bit more about those symptoms for posterior circulation strokes. So there are the 5 Ds: sudden dizziness, double vision, and then there are also other visual symptoms as well, dysarthria, or kind of like a slurred speech, dysphagia, difficulty swallowing, dystaxia, unsteady gait, as well as uncoordinated movements of the arms or legs. Some other symptoms: altered consciousness, headache, nausea, vomiting. Those are more likely in posterior circulation strokes. Again, abnormal eye movements, blurred vision or visual field defects. Those cross findings, which are pretty specific for brainstem strokes. There is this red flag for to think about a posterior circulation stroke, and that's a history of neck pain or trauma which might indicate a vertebral artery dissection. So back to the types of stroke. So we talked about ischemic strokes. There are also hemorrhagic strokes. And typically when I think of a hemorrhagic stroke, it's an intracerebral hemorrhage, so hemorrhage within the brain tissue. But sometimes these subarachnoid hemorrhages can also be classified under hemorrhagic stroke. So subarachnoid hemorrhage is the typical hemorrhage that you'll get with a aneurysm rupture. And so the blood is really on the surface of the brain along the blood vessels rather than within the brain tissue. You can get blood within the brain tissue, but most commonly it stays on the surface of the brain and the grooves of the brain. Within these types of stroke, the common stroke symptoms, intracerebral hemorrhage, there's a lot of overlap with ischemic stroke symptoms because it's based on what area of the brain is involved, but you're more likely to get nausea, vomiting, and headache with an intracerebral hemorrhage, as well as decreased consciousness also. Subarachnoid hemorrhage from an aneurysm rupture is symptoms typically include thunderclap headache or worst headache of life, photophobia, intolerance to light, maybe neck stiffness and pain. Oh, whoops. And just to, so you can see here, this is actually an image of a ruptured aneurysm. So these are where the blood vessels reside, so that's where you see the blood layering. This is an intracerebral hemorrhage that's within the brain tissue, and then subarachnoid hemorrhage that is within the grooves of the brain. Okay, so again, with intracerebral hemorrhage, these are some other types of intracerebral hemorrhage, some types of intracerebral hemorrhage. So this side is secondary hemorrhages, so there's some other underlying issue, and then there's a hemorrhage on top of it. So this is a tumor that hemorrhages. This is a vascular malformation that hemorrhages. This is related to infection coming from the heart. These are the primary intracerebral hemorrhages. So there's two main types. Hypertensive hemorrhage, which is related to blood pressure being very high, and then amyloid hemorrhages.
What's an amyloid hemorrhage?
I'm gonna.
Oh.
So amyloid, these are some more examples of amyloid hemorrhages and hypertensive hemorrhages. So amyloid hemorrhages occur more often in the elderly. You can also get hypertensive hemorrhages in the elderly, but you also see them in like people in their 40s. Amyloid hemorrhages are basically as we age, you can get deposits of amyloid, which is this protein, but deposits of amyloid in the like microvessels, the tiny vessels of the brain, and some people get more of that than others. And so in people that have an amyloid hemorrhage, they typically have enough of those amyloid deposits that those vessels become friable and easily rupture, and then you get hemorrhages like this. So in amyloid hemorrhages, you get more of these like lobar hemorrhages, and they're a little bit more peripheral compared to hypertensive hemorrhages. With hypertensive hemorrhages, there are like very typical areas that you see in a hypertensive hemorrhage. So this is a hemorrhage in the basal ganglia, which is the most common location for a hypertensive hemorrhage. And so you'd likely see symptoms common to what you would see for an ischemic stroke of one side of a hemisphere. So typically weakness on the opposite side of the body, and the face, slurred speech, things like that. But you may also get things like headache and nausea, vomiting, because you have this increase of blood in the brain, and which can increase the intracranial pressure, or the pressure inside the head. So this is a cerebellar hemorrhage. So you typically get also headache, nausea, vomiting, but unsteady gait, maybe trouble with coordination on the same side of the body. So some stroke mimics. Probably the most important for you is hypoglycemia. That's why we always check. It's very simple to check the glucose immediately, and so that's the reason we do check for that. But you can get like an epidural or subdural hematoma that might present the same way, infection, seizure or brain tumor, migraines. So there are other things that can present like a stroke. So stroke treatment. So what do we do once the patient gets to the hospital? So if the patient arrives within 3 hours or potentially 4.5 hours, then they may be eligible for TPA or TNK, thrombolytics. If they are not eligible, well, I should say, whether or not they are eligible for a thrombolytic, they may also be evaluated for whether they are eligible for a thrombectomy. If they arrive after 3 hours or 4.5 hours of symptom onset, then they won't be eligible for a thrombolytic, but they may be eligible for a thrombectomy. With medical management and thrombectomy, again, the time window for a thrombolytic, TPA or TNK, is 3 hours. Sometimes within 4.5 hours, the stroke neurologist may decide that it is okay to still give TPA or TNK. For a thrombectomy, they are typically evaluated if they are within 24 hours for symptom onset, they may be eligible for a thrombectomy. Thrombectomies are done only for large vessel occlusions. So if there is imaging findings that there is a large vessel occlusion, then they'll evaluate whether they can get a thrombectomy. These are the main research findings that led to use of thrombolytics and thrombectomies. Both have been shown to improve outcomes in stroke patients within the time frames that I discussed. So there are contraindications to thrombolytics. So a prior brain hemorrhage, recent neurosurgical procedure, clotting impairments, and so potentially anticoagulants. So it is important for us to know that information. It's very helpful when you guys are able to obtain that information about medical history and medications, to know whether they could be candidates for IV thrombolytics. This is just kind of documenting the evidence for use of thrombectomies. They have been shown to improve outcomes when within 6 hours from onset, no hemorrhage on the CT, and then there is a large vessel occlusion. So this was specifically proximal MCA or ICA occlusion, although thrombectomies are used in other large vessel occlusions as well.
So if you've got a patient that's in the window for lytics,
Mhm.
is your preference to still go to do a thrombectomy or to go with lytics?
So,
If you've got the ability to do a thrombectomy, is that your preferred route to?
so actually they'll do both.
Okay.
So they'll get a thrombolytic if they are able to get a thrombolytic. So in some ways it's kind of they're kind of separate protocols.
Sure. Understand that.
So you can get both. You could get a thrombolytic but not be a candidate for a thrombectomy. You could not be a candidate for a thrombolytic but get a thrombectomy.
Complications for thrombectomies are lower than lytics though, aren't they?
I don't have a good number on that. So,
Just intuitively, it would seem like a thrombectomy wouldn't carry the risks and maybe even as many.
so there are different risks
Sure.
with thrombectomies, like including like spreading off tiny blood clots and causing like small other strokes in the brain. From the like groin puncture itself. I'm not sure what the number is in comparison for like total complications. Definitely, if they're a candidate, so some people, they can have a large vessel occlusion, and they may be getting considered for a thrombectomy, but they actually improve with thrombolytics, and so they don't even need that
Sure.
procedure. If you can also avoid that procedure and you're getting the thrombolytic, then that's also the option that we go with. This is the early window. So how do we manage patients in the early window? So this is they're presenting within 6 hours of stroke onset. So they'll get a head CT and a head and neck CTA, and then if they're eligible for TPA, they'll get TPA. And whether or not they're eligible for TPA, if the CTA shows a large vessel occlusion, then they will likely get a thrombectomy, or at the very least considered for a thrombectomy. Again, if they improved with TPA, then they would hold off on a thrombectomy. So then, what do we do in the late window? So that's after 6 to 24 hours after symptom onset. So they wouldn't be candidate. They wouldn't even be considered for a thrombolytic. They would get a CTA head and neck and typically a perfusion scan of the brain. And then they may be, this is kind of showing it as two different parts of the decision tree, but there can be overlap as well. So if the CTA shows a large vessel occlusion, if there's a large vessel occlusion, but the core is small, core of the stroke is small, and there's a large penumbra, then they could be considered for a thrombectomy. So what do I mean by penumbra? This is, so basically this is showing a blood clot in this artery. So this is the core of the stroke. So this is brain that is irreversibly damaged. And then this is the penumbra area. So that's the part of the brain that is at risk of irreversible damage, but may be salvageable with a thrombectomy. So again, this is another example of a thrombectomy, but, so this image is, on this side you can't see the blood vessels here. And then this is after thrombectomy, they've restored the middle cerebral artery branches. So let me go back to that decision tree. So there are some patients that may show a large vessel occlusion, but they have a large core and either no or small penumbra. So that means that most of the stroke area shows irreversible damage to the brain, and there is not a significant amount of salvageable tissue. So those patients are typically not candidates for a thrombectomy, and they typically are considered for a decompressive hemicraniectomy. So I'm gonna talk a little bit more about that. Okay, so this is a patient that had a middle cerebral artery stroke. So all this dark area is the middle cerebral artery, is where the middle cerebral artery supplies the brain. You can also, I think, see that there is a shift of the brain to this side. Like when we're looking at a CT scan, we're looking for symmetry. And so you can see how this part of the brain that has infarcted has also expanded because of swelling. So these images show some of the blood supply of the brain. So the middle cerebral artery supplies a large part of the brain, and the location also puts patients with large middle cerebral artery strokes at risk of brain swelling and herniation. So when the brain is injured in some way, either by trauma or, a stroke is also a type of injury to the brain responds by swelling. And there's only so much room inside the skull, and so that swollen brain, basically everything in the skull, when that brain swells, it has to go somewhere, and so the brain herniates, and it basically, brain tissue herniates downwards out of the skull, which I think you can guess is is potentially mortal. So these patients, we often consider them for a decompressive hemicraniectomy. So this is kind of the typical incision. So this is where the face would be, but basically we make a large incision on the side of the head. This is also showing the type of incision that is typically made. This is showing after the scalp has been retracted, and then this is the dura, it's a membrane on top of the brain, so that's also cut open and retracted. And basically what this does is give the brain room to swell. So it doesn't treat the stroke itself, it just treats the kind of secondary, prevents some secondary injury. Basically allows the brain room to swell so that it's not herniating downwards and causing more damage and potentially death. So typically what we do is basically leave the bone off, and obviously, the scalp is closed, but the bone is left off for a few months and then is replaced after the brain swelling has resolved and there's been some recovery for the patient. Sorry. So this is another type of decompression surgery for stroke. So these are the cerebellar hemispheres. So this dark area is stroked cerebellum. And so this is also an area that the cerebellar hemispheres are much smaller than the main hemispheres of the brain, the right and left hemispheres of the brain, cerebral hemispheres, but they're in a smaller area of the skull. And so people with cerebellar strokes are at risk of, also at risk of herniation when there is swelling. So so basically this is the kind of incision that we make on the back of the head, and then this is the bone that gets removed. And you can see here, so all this white is bone, and you can see here where it's been removed. And actually the cerebellum, because of the swelling, is basically taking up the space where the bone was, and also even beyond it. So same thing, basically allowing the brain room to swell. In this area, we actually don't have to replace the bone. And so they basically just they have just kind of like a normal surgical healing afterwards and don't need an additional surgery. So going back to intracerebral hemorrhage, so the treatment is mostly medical, so managing blood pressure, if they're on blood thinners, then reversal of those blood thinners, if they have a coagulopathy or correction of the coagulopathy. But there are some surgical options in certain patients. So some of these patients can be candidates for a clot evacuation, either through like a larger craniotomy or through a minimally invasive approach. So this is a patient that had a hypertensive hemorrhage. This is it looks like it originated in the basal ganglia, and then it's also involving the ventricles or the fluid spaces in the brain. But this is after surgical evacuation. You can see how much of the clot was able to be evacuated. This kind of shows how we plan one of these surgeries or navigate during the surgery. We use a CT or MRI within the surgery. I mean, we actually plan beforehand, but then we register the patient to the scan and basically use that to actually guide us during surgery. So this is the trajectory. This is actually, you can actually go within the one of the wrinkles in the forehead and make a small incision and a small hole in the skull and pass a catheter. So this is one where they basically passed a catheter and then you can see the attached syringe and basically suctioned out some blood clot. That's only a potential option if the hemorrhage has been stable over about a day or so, because otherwise you're at risk of creating more bleeding, and then you don't have direct access to be able to stop any of that bleeding. And so this is showing where a catheter was passed. These are two different patients and types of hemorrhage. So this one was a different hemorrhage in the temporal lobe, and so you can see where a catheter was basically like kind of more directly passed within the hemorrhage. These are some other minimally invasive, but not quite as minimally invasive. It's just passing a catheter. But with these, you actually have visualization within the blood clot and within the brain. So again, you use navigation, but basically this is where you pass in a port into the blood clot. And this is kind of showing how you find a groove in the brain, you go down the groove. The way the port is designed is to kind of separate brain tissue safely in order to clear a path. And this is also kind of similar, but using an endoscope, which is similar to like a laparoscopic procedure. But again, you have some visualization within the clot. And if you see tiny bleeders or something, you can actually address those in surgery. Stroke protocols. So types of stroke hospitals. There are acute stroke-ready hospitals, which can stabilize the patient, maybe give TPA or TNK, but the patients are typically transferred. The primary stroke center, which can give thrombolytics and are often able to admit patients, although they may need to transfer. Davis is a thrombectomy-capable stroke center, so it's a primary stroke center, but also has 24-hour coverage for potential mechanical thrombectomies. We do still sometimes have to transfer patients to a comprehensive stroke center, which is the University of Utah is a comprehensive stroke center. And so they're basically capable of, again, capable of thrombolytics and thrombectomies, but also have neurocritical care, some additional infrastructure. There are some thrombectomies that may be a little bit more complex, and so sometimes the patients get transferred to the Comprehensive Stroke Center. So recommendations for EMS. Obviously, ABCs to start with. Performing a pre-hospital stroke assessment, which I'll talk a little bit more about. Getting information on medications, getting family information, comorbidities, medical history, providing advance notification to the receiving hospital, and then often checking a glucose level. So EMS use has been proven to lead to earlier arrival to the emergency rooms, faster evaluations, faster time to imaging, faster time to treatment, with potential thrombolytics. So just to show kind of the importance of what you do in helping these patients get to treatment in a timely fashion. So pre-notification systems, have also specifically been shown to decrease time to imaging, decrease time to treatment. This is kind of more of a national study, but it did show that about 67% of stroke patients transported by EMS have pre-arrival notification to the destination hospital. But it is very important in getting stroke treatment faster when we get pre-arrival notification. And again, each minute, for a large vessel occlusion, again, each minute there could potentially be 1.9 million neurons lost. So stroke assessment and severity tools. So, when you're evaluating a patient, you use a pre-hospital stroke scale. You may, if that's positive again, may also use a large vessel occlusion stroke severity scale to determine whether they have a potential large vessel occlusion. It may also make a difference as far as what hospital you're taking them to. Again, Davis is a thrombectomy capable hospital, so can treat large vessel occlusion strokes. Pre-hospital screening tools are, especially in anterior circulation strokes, identify most patients with strokes. This study showed that with the stroke assessment training, the sensitivity of identifying strokes went from in the 60s percentage to 86 to 97%. That's with a training for a stroke assessment. There are several pre-hospital screening tools. The Cincinnati Pre-Hospital Stroke Scale is the most widely used. Identify whether there's facial droop, arm drift, speech. Is this what you guys use? Okay. And the other stroke scales there's a lot of overlap, very similar. So if any one of these three signs is abnormal, the probability of stroke is 72%. If all three findings are present, the probability is more than 85%. Over. So again, as I talked about before, the posterior circulation strokes are less represented by these pre-hospital stroke scales, and again, also the in-hospital stroke scale. But it is quick and easy to use, and it identifies typically 80% or more of stroke patients. For layperson stroke recognition, you've probably seen this before, the FAST mnemonic. So face drooping, arm weakness, speech difficulty, and then time to call 911. There has been a push, from us as well to make it be fast. In addition to face, arm, speech, and time, there's also balance, so sudden loss of balance, sudden dizziness, and eyes, so change in vision, visual symptoms, and as I kind of talked before about the symptoms of posterior circulation strokes, with BFAST, this does identify more of those posterior circulation strokes than just using FAST. So stroke severity scale. So after a pre-hospital stroke scale, you may use a stroke severity scale, which is supposed to be helpful in identifying large vessel occlusions. There are several scales that can be used, and there is a lot of overlap in the scales again, so they typically, in addition to some of the other stroke symptoms that are part of the like Cincinnati stroke scale, they may include something like gaze deviation, aphasia, agnosia, maybe like a neglect, like they don't know their arm or leg is their own leg, they don't recognize it, something like that. These are some of the examples. This is the Cincinnati Stroke Triage Assessment Tool. So it includes level of consciousness and gaze deviation. So a score of greater than or equal to 2 is associated with detection of a large vessel occlusion. It has a sensitivity of 71%, specificity of 67%. So I think I forgot to mention this, but there are several scales for large vessel occlusions, but none of the scales have both a high sensitivity and high specificity. So what that means is, so sensitivity is basically identifying most of the strokes. So a higher scale with a higher sensitivity will identify most of the strokes. But you'll also have, you may also have false positives, sorry. People that are identified as strokes but not having strokes. And then high specificity is basically the opposite. So if a stroke is identified by a scale with a high specificity, then it most likely is a true stroke, but you'll miss more strokes. None of these scales has both a high sensitivity and high specificity. So it can help in identifying some large vessel occlusions and maybe giving a heads up to the hospital. But again, there's definitely room for improvement with these to better identify large vessel occlusions. This is just to show you the scale that we use in the hospital for evaluating patients. This is the NIH stroke scale. There is definitely some overlap with the pre-hospital screening tools, but then you also get some additional detail as well, like level of consciousness and gaze, and a test for neglect. And then these are showing based on the total number, whether we consider that a minor stroke, a moderate stroke, a severe stroke. So conclusions, stroke is treatable, time definitely matters, time lost is brain lost. Obviously a stroke screening tool is definitely helpful to identify potential strokes. Could potentially be helpful with large vessel occlusions as well. And just want to reiterate the importance of advance notification to the hospital as well. Okay, questions?
How often are you doing thrombectomies there versus shipping? Where we do interfacility, trying to help us gauge like,
Sure. So I will say that recently, it's been a little less. We've gotten a few more, either the vessel is, so we've had a couple where, I don't know how to, so like within the middle cerebral artery, if it's right off where the middle cerebral comes off, that's the typical location, but sometimes you can get it off of the next branching of the artery. And so that's something that our endovascular physicians have felt is better served to do at the U. And then sometimes when they involve the carotid artery, depending on how it looks on the scan, sometimes they'll say, well, maybe. But most thrombectomy, most of the large vessel occlusions that can get thrombectomies can be done at Davis Hospital.
and then just because we do interfacilities from there, so different from like going to a house or a business and identifying a stroke patient. Patient's already identified a stroke, somebody that we're taking by ground down. What kind of things like blood pressure management might they expect to be doing? Does that make sense? So what interventions might we be continuing on some of these patients? Just because we've got some newer medics and newer folks here to kind of get an idea of what they could be confronted with.
Sure, so, I mean, so the main thing will be supporting ABCs, checking glucose, if that's something you do.
It is.
As far as blood pressure, so there's, we're a little bit hesitant to give, wait, actually, what's our recommendation right now? I think we just updated it,
Labetalol or a nitardipine drip.
but blood pressure level.
Oh, sorry, so what it is, for a thrombectomy, if they patch TNK, it's 180 over 110. It has to be below that.
Sorry, are you talking about a patient that you get and you're bringing to Davis, or that you're
That we're
taking from Davis to the U?
So
Oh,
in the
okay.
event that you didn't fly
So then it
them,
would be the normal, if they had TNK, you would do the normal, keep it below 180 and 105 once you've given the thrombolytic. Because your blood pressure when you do a thrombectomy is dependent on how open you get the vessel, which isn't something that you would have already done. So you would just be keeping it either if they had TNK, the regular TNK blood pressure, or if we didn't give TNK, they'd probably just do a permissive hypertension. You might not even necessarily be on a drip per se.
And that's because you want the brain to still be perfused, so there is the one other thing I should mention is that, if there is a concern about blood pressure, like I wouldn't hesitate to go to cardine, rather than like keep pushing labetalol. Because, especially like for patients,
I've noticed that when they'll do like hydralazine and labetalol, and it does nothing, and then as soon as they put them on the drip, the cardine, it works great.
Yeah, and it is important, especially like for somebody who had TNK, that we do get the blood pressure down. So obviously we don't want it to get too far down either, but we do want to get it controlled quickly. Anything else that you would say as far as for when they're transferring? Can't think of anything else to recommend specifically.
Yeah, so just neuro, you just watch for TNK.
Yeah, just like monitoring neurostatus
There's
and
really no
letting the
difference
hospital know if there's any change.
in
That would probably be
TNK
the
and
only thing.
ultraplace either. They're exactly monitored the same, risks are the same.
Right, so I
So there's
didn't
nothing
mention
unique.
this, but yeah, so Davis is now giving TNK, tenecteplase, and that's mostly for ease of administration. It's just, rather than a drip, it's a push, and it's easier for the setup for administration. But there's been no, otherwise there's not a benefit on top of TPA, and there's not a additional risk on top of, compared to TPA, excuse me. So as far as like efficacy, and potential for better outcomes, that's the same with TNK and TPA.
So we're not gonna be continuing an
You
infusion
will
of
not
that
have
like we were
infusion.
Like
before.
when we did
Great.
TPA, we had to do it over an hour, you guys just continue
Yeah.
that, but
Right.
now it's
You won't.
bolus push.
One push and you're
Thank
done.
goodness. So
And
much
you'll
better.
notice, I'm not sure about McKay, but Ogden Regional, their hospitals have changed to TNK. All of Holy Cross is TNK now. Does the U mix, or do they still just do Altaplase?
I'm not sure. I mean, the last I heard they were still doing TPA, but I'm not sure if that's changed recently. Yes.
So you said with like TPA or TNK, the patient improved outcomes was about 40% approximately, like showing improvement over time. What's the other 60%? So you're talking about like if they receive it, like versus the medication administration versus the thrombectomy, like they were like in the 30s to 40% improved. I'm just curious what the other, is there like some that it doesn't work at all, some that get worse?
Oh, I don't remember
Yeah.
where I had that number, but yeah, definitely thrombolytics don't always work. You can, so they can, progress to, a complete stroke, so, like infarcted brain. They can potentially get worse as well. Sometimes the stroke can get worse, but usually it's just that they don't have any improvement. So as far as the people that don't respond to thrombolytics, if they're a large vessel occlusion and they don't respond to thrombolytics, they may still be a candidate for a thrombectomy, which does have a higher chance of an improvement. But even with the thrombectomy, there are definitely some that, like in the cath lab, they'll basically do like 3 thrombectomies, but there's a new clot basically, or the clot kind of reforms. And so they just, at that point, they're just gonna progress to a complete clot. There's really nothing we can do. So we have kind of all those scenarios.
Cool, thanks.
Well, thank you. Appreciate your time.
Oh, sure, yeah, of course. Thanks for having me.
Do you guys wanna get lunch while we set up so you guys can watch the video?
We'll grab sandwiches. There's drinks back there, sandwiches back there, there's some ice.
Thank you, Doctor.
Pat, you guys are getting lunch, I think, sent to you, 54?
Yes, it already got delivered.
Okay, you should have lunch.
Oh, I forget. I was like, who are you talking to?
Those guys.
Those guys.
We gotta figure out how to put them on that screen. Like put this on that screen.
I get it.
That one looks like.
Mine's a big. You should be able to get rid of them altogether.
Thank you, appreciate that. I follow like patient, I don't know if you were